Hello, everyone. This is Pradeep. And first of all, happy holidays. For those of you who celebrate Christmas, Merry Christmas. Those of you who don't celebrate Christmas, happy holidays. And I wish you and your family to have a great holiday season. And I hope that you take the time to celebrate just the being alive, being together, and being grateful for everything that we have in our lives. So again, I hope for all of you to have a great new year coming up. And we have a great session, a lot of questions today to cover. So let's get started. The community has sent questions in since the last AMA, which was about 2 weeks ago. And as far as I see, 20 questions approximately cover all your questions. Many have been repeating questions, or we have grouped them into a larger question to be answered. So we have much to discuss. So let's get started. Question number 1. The ultimate vision and mission for Solve.Care is to be the Amazon, Salesforce, and Visa of healthcare. Can you explain to the world and community what you mean by this? What you expect and how and when the platform can reach this very great height? So the Solve.Care platform, being a platform, is designed to serve 3 fundamental needs of healthcare: clinical care delivery, care administration, and financial payments of healthcare. So 3 pillars of healthcare: clinical, administrative, and financial. We believe that those 3 pillars need to intersect, that there are many solutions in the market that address one of these pillars individually. And further, each of these solutions focuses on a very specific problem, such as a specific disease or a specific reimbursement model. So there are many solutions for insurance companies, and there are many solutions for employers and employee benefit management. There are many solutions for TPAs, the third-party administrators, or accountable care organizations. There are tons of solutions for hospitals to manage their hospital systems better. But the problem in healthcare is that these systems are indeed narrow point solutions. They do a job and they not often do it well, but they don't do very well when it comes to interacting with other systems. So you end up with this whole collection of systems that don't talk to each other. And that's not a small problem. When I was at Blue Cross, we had a portfolio of vendors, and these vendors gave us different technologies. Some vendors gave us the eligibility system, or the enrollment, or the member management, the benefit management, the claims adjudication, the payment, the EFT, the EDI, tons and tons of systems. But the problem was how to get them to talk to each other. And that was a near impossible mission. So majority of what the IT budget for Blue Cross, and it was very large budget, was spent on trying to get these systems to talk to each other, or somehow to move data between them. Because frankly, most of these systems will never talk to each other. They're not designed to talk to each other. You can't really take an engine out of Honda and stick it in a Tesla and say, well, interoperability should allow me to do that. There are 2 different platforms. They're not designed to interact. So in healthcare, whether you are a hospital or you're a government agency, you're an insurance company, you're an employer, you're an employee benefit broker, you're a pharmaceutical company, you're going to have your own systems and they will do something for you. But the moment you have to interact with somebody else, it doesn't work. So our vision has been that we need to stop building these siloed systems and start imagining relationships in healthcare that can operate on a single platform. And every healthcare transaction between different parties, A and B, B and C, C and A, can be ultimately configured as a relationship, and related processes and related data and related permissions and related payments and related regulations, all of that to be configured in the context of a relationship between you and me, between me and my doctor, between my doctor and the specialist, between my specialist and the nurse. If we divide the healthcare world into its most fundamental building block, it's an interaction between 2 parties who need to coordinate and collaborate on making you or I feel better as a patient. Now, when you look at that platform capabilities, it has to do all of the above. It has to give the ability for payment between parties. It also has to allow payment for each other for third parties. So typically in healthcare, when I go to the doctor, I pay only part of the bill. The other part of the bill is paid by somebody else, typically the insurance company, or my government, or my employer. And it gets really complicated when that other part of the bill that needs to be paid on my behalf has to be split between more than one party. So if you have two insurance plans, primary care and let's say Part D for drugs, you end up with two insurance companies paying the other part of the bill. Or if my employer is paying for part of my insurance, you have high deductible plans where the employer covers catastrophic risk. So you see, in healthcare, payments are not as simple as Visa. So to say that Visa of healthcare is needed is true, but Visa of healthcare won't be like Visa, because Visa is between two parties. Visa allows you to pay the vendor, the merchant. You go to the store, you swipe your Visa card, Visa takes money from your credit account, pays the vendor. That's it. So the payment goes on your behalf from party A to party B. Visa just facilitates that transaction. In healthcare, it's much more complicated. Not only does Visa have to move money from your credit card to the merchant's bank account, they also have to figure out how much money you needed to pay and how much more needs to be paid, and is that amount correctly billed, and is that amount should be paid by the employer or the insurance company or the government agency, and then bill them and then collect it after 90 to 180 days later. So frankly, Visa of healthcare is not going to look anything like Visa, okay? And that's what Solve.Care solves, the problem of dealing with multi-party interactions, multi-party responsibilities. So we have built a platform where you can define these relationships between patient-doctor, which is what you would call a co-pay relationship, where I pay part of the bill. And then there is a doctor-insurance relationship. Then there is an insurance secondary insurer relationship. And then there is a doctor billing relationship. So all these relationships can be defined on the platform to actually make healthcare's Visa reality. Now, we believe that while there are many solutions that solve a specific problem, nobody has built a platform like Solve.Care to solve all the problems. And not only that, we have further tokenized the payments. So when appropriate, payments can be made cross-border instantly without the friction of banking or credit card or debit or ACH or EFT system, because those systems do not operate. They're not programmable. Solve.Care is building a programmable payment system, not only building it, but has built it. And that programmability comes in the form of care cards, which can be configured to an event or to a lack of an event, and it can allow multi-party payments to collaborate on a single care episode. You and I going to see each other, you're the doctor, I'm the patient, I come see you, seems like a simple enough problem. I go see the doc gets paid. It's a very complex problem, because if I don't pay you the 100% of the bill, then a lot of people have to get involved in figuring out who, when, and how much is owed to the doctor beyond what Pradeep paid upon the visit. And even if I'm paying the doctor the 100% of the bill, who decides what the right amount of the bill should be? Because we're not just buying a sweater here, we're buying healthcare. And healthcare costs is also regulated. The doctor can't just charge me whatever they feel like. There has to be certain rules the doctor has to follow in billing me. Those rules need to be validated. If there's not an insurance company enforcing some rules, then there'll be a government agency enforcing some rules. So rules of billing and rules of payment are very complex in healthcare. So Visa of healthcare is going to look nothing like Visa as we know it. And that's what Solve.Care has built. And the combination of care cards and care wallets and Solve token makes programmable multi-party payments possible. Now, of course, you can do all that without the platform, right? I mean, I was paying hundreds of millions of dollars in payments to doctors every month. We didn't have Solve.Care back then. So what's the big deal? The big deal is it's really expensive. It's really difficult. It's full of fraud. It's a lot of waste. So yeah, before computers, we used to do math and repetitive tasks with mechanical engines or with just the bodies. There weren't computers, and humanity survived without computers. But humanity does a lot better with computers. Before mobile phones, we still knew how to talk to each other with regular rotary lines, but you had to stand in line to call your friends at a specific hour if you were traveling abroad. Cell phones changed our life. And then they went from being communication devices to life-changing devices with all the apps. So yes, progress, you can live at any given epoch in time and say, well, healthcare seems to be working all right. Why to make it better? Well, look, the world existed before e-commerce and internet too, but do you really want to go back to the days where you had no internet and no GPS and no Google and no Apple? And do you really want to have to stop and ask for directions instead of relying upon Apple Maps and Google Maps? So world keeps getting better and better. And we are trying to make healthcare better by saying, let's rethink the whole healthcare payment framework by making it programmable. And the programmable authorizable care cards will address every payment scenario, be it patient-doctor direct payment, be it patient-doctor partial payment, be it patient pays doctor nothing and the doctor collects the money from insurance company and figures out the difference and then collects the balance from the patient. Or maybe it's family pooling of money, or his employer pays part of the bill and the patient pays the other part and the insurance company pays the other part and the government jumps in and pays the other part. Maybe we will actually move towards a completely self-pay model where we can have individual risk pools where patients pool their money and become self-insured instead of the employer being self-insured. There are 1,000 possibilities. The reason those possibilities need to exist is because healthcare system doesn't serve everyone equally. If you're lucky and you have good healthcare reimbursement behind you, like an insurance company or a government agency like the NHS, or in Canada, the provincial or the national government, you have a different payment problem. But if you are self-pay, it's a totally different payment problem. We are not saying that we know the best answer for healthcare for every part of the world, but we do know that in every part of the world, healthcare can be made better. And our system is designed to make healthcare programmable. Now, in a simple statement, we have envisioned that every healthcare transaction is essentially an exchange of cards. I send you a card, you respond with your own card. That exchange of cards gives us the ability to solve any healthcare exchange of information, privacy, consent, data, payment, everything. So the idea is what Steve Jobs did with iOS. See, iOS is essentially a deck of cards. The whole iOS operating system, its core premise is an inherited deck of cards. Now, that makes sense. It's an operating system that's designed to essentially layer on cards and swipe between cards and put cards inside cards and put more cards inside those cards. And you create this beautiful three-dimensional model of cards that eventually powers every phone in the world. We have taken the same principle and we built a deck of cards, or rather a card-based system for every single element of healthcare. So first and foremost, we are Visa of healthcare because we let programmable cards, or authorizable cards as we call them, move between wallets at the right time with the right consent and the right permission and the right content and the right value. And because you can attach value to the card, you can move money when you move cards between wallets. And that makes Visa of healthcare possible. And that's why I keep saying Visa of healthcare will look nothing like Visa. Now, there is a second element of healthcare, which is the Amazon side of it. What does that mean? So the Amazon side of healthcare is having access to healthcare. How do you get access to healthcare before you can even pay for anything? How do you know which doctor to choose, which pharmacy to go to, which lab to get your test done, how to find a specialist, and how to even know that even you do have access to the care locally? Is it the right care? Are you getting the best possible care? And are you getting the best value for your care? So the Amazon side of care is about access, about choices. Now, we have taken a very innovative approach to becoming the Amazon of healthcare. We have created the concept that every care organization, be it a hospital, a pharmacy, a lab network, an individual therapist, or a home aide, or a chiropractor, or a doctor, or a group of doctors, or a small hospital, or a big hospital, these are all sellers. They sell something to you as a patient. They need to publish their product on the Amazon of healthcare, right? Because if there was nobody selling anything, why would you go to Amazon? Why would you go to Amazon if you couldn't buy a thing on Amazon or on any other e-commerce platform? You go there because you have choices. You go there because you can browse between these options and choose the sweater you actually want. If there was only one sweater for sale, you probably wouldn't visit Amazon. Now, healthcare is much more complex when it comes to delivering sweaters. Because in healthcare, it's not a transaction, it's an episode. When you sign up to go to the doctor, you're not just going there for a visit, you're going there for the doctor to stay with you till you get well, whether that journey of getting well is 3 days, 3 weeks, 3 months, or 3 years. You want to get well. You are looking for a care journey. You're not looking for a care transaction. Sending a card and receiving a card does not get you well. Staying on the care journey gets you well over time, which means you also need to know what to do with your diet and your nutrition, with your diet and with your prescription and with your lifestyle and your alcohol and your sleep and your stress so that you actually get well. It's a full package. So healthcare is delivered not like a sweater being sold, but rather a care journey that you walk hand in hand with the doctor. And care journeys are multi-step, complex journeys, and they need to change based on how well you are doing. So we reimagined healthcare away from transaction to a journey model. And we said, let anyone who has the ability to serve a patient publish their journey on the platform. If you are a chiropractor, you can publish certain care journeys that make sense from a chiropractic perspective. If you are a specialist in endocrinology, you let your care journeys reflect the unique circumstances and approaches to delivering care to those who need endocrinology-related care. Every care journey has to be different because every care journey, first and foremost, begins around what disease condition we're dealing with, and second, the unique conditions of the patient. So imagine a scenario where you were told that no matter what your age, your gender, or your disease condition is, this is the standard model of dealing with your health condition, and you don't even need a doctor then, right? You could just Google it and say, what's the care journey for your scenario? Why would you need a doc? The reason you need a doc is because you need the journey to be customized for you. So we decided that we are going to give everybody on the planet, every care provider on the planet, an option to build and publish care journeys that the patient can then subscribe to and use. And those care journeys can be generic or highly specialized. And further, those care journeys can be modified by the people who know how to build and modify care journeys, namely the clinical care provider, the sellers, the vendors on Amazon. In this case, are doctors and nurses and pharmacists and chiropractors. And they're not selling a sweater, they're selling a care journey. And we allowed them to author care journeys. And that brings us to becoming a global marketplace of Amazon, but way more complex than Amazon. So the Amazon of healthcare will look nothing like Amazon, because Amazon facilitates a transaction. We facilitate an outcome. Amazon facilitates you choosing and buying a pencil. We focus on making sure that the essay that is written is accurate and it serves your best interest. We're not selling the pencil, we're selling what is written with that pencil to ensure that you have the right instructions to take care of yourself. So we are the Amazon of healthcare without being limited to the transactional view of most e-commerce platforms. We have to do everything they do, but we have to do a lot more. Then we get to the third part. Why do we call ourselves Salesforce.com of healthcare? Well, of course, they are a great company, and I'm a big fan of Mark Benioff, and I think he has led this company to amazing heights, and he is someone to emulate. A lot of people emulate Jeff Bezos and, of course, Steve Jobs. Most of us would like to be them, but I see Salesforce as a company that built a B2B platform that actually works. And we are a B2B2C platform. So we need to learn from the best of the best, and Salesforce is a great example to learn from. Now, what does Salesforce let you do? It lets you configure business processes. It lets you define the business processes between parties, B2B and B2C. They started off as a B2B, and then they're moving slowly into B2C and even B2C in some cases. So business to business and business to consumer need to live side by side. And we know that. We know that our client is a doctor, but the doctor's client is the patient. So we need a B2B and a B2C capability in our platform. And Salesforce configurability, their app exchange, And their focus on community-built products, community-built solutions is our vision. We want every one of you to be enabled and empowered to build solutions on our platform. We want you to be able to work with a local doctor, your primary care physician, or your regional hospital, or your pharmacist, or even your uncle who tends to be a wellness expert or a dietitian, and help them build care journeys on the platform. So Salesforce's model of community-built solutions that clients can use is exactly our model. We have emulated that. So both in terms of business process authoring and in terms of ease of authoring, and going beyond that and saying, we don't build, we aren't the author, we help you be the author, are the concepts that we have borrowed from there. So when you bring it all together, Visa but better than Visa, Amazon but better than Amazon, and Salesforce but better than Salesforce, that's what healthcare needs. That's a bold mission, bold vision. Nobody's ever done this before, but we have. And I'm so excited because now we are at a point where these things come together. People always ask me, hey, you've been on this journey for 5 years. How do you feel about it? And I say, well, first, I've been on this journey for 35 years. Ever since I set foot in healthcare as a young man, as an intern, I have questioned the wisdom or the lack thereof in the way healthcare is managed. And why do we do this insanity of building silos and then trying to connect them later, which they will never connect? So I've watched and learned and always wondered when we're going to do something different. And eventually the answer came to me 6 years ago that it's time for me to do something different because nobody else will. 6 years ago, I didn't know how long it will take. I was prepared for 10, even 15 years of a journey. But I'm incredibly excited and proud that at the 6-year mark, we are where I wanted to be. We have the ability to author journeys. We have the ability to program money, and we have the ability to create a B2B framework that exceeds anything in the market that anyone has ever seen. Because care networks give us that safe space for a client to build their own care network, assemble their own journeys, publish their own cards, invite their own participants, but then the wallet connects all these networks together in the form of card interoperability. And nobody's done this. Nobody has even dared attempt it because it's too big. And I thought it might take us 10 years, but here we are. And I'm really proud of that. So we end the year 2022 with an incredible excitement that we have breached that milestone. We have exceeded that boundary where now we can say we are the best healthcare platform the world has ever seen. That doesn't mean we are done, that we're going to go home now and celebrate. It just means that we are getting started. We're getting ready to fire up because we can bring the best of Amazon, best of Salesforce, and best of Visa into one single care network. And you don't have to build any more silos because everything you build will interoperate with everything else anybody else builds on our platform. So are we ready for the great heights? Yes. Will we change healthcare? I absolutely believe so. I don't have a crystal ball to tell you whether we will dominate the healthcare landscape in 3 years or 10, but I know for sure that if we stay on course, we will be the player everybody will use. We will be the platform everyone will use because there is no better solution. And I think competition will come. People will say, oh my God, these guys have done something that was considered impossible. I want to copy them. And emulating somebody is a lot easier than envisioning and doing something that nobody's ever done. We have done the hard part. Now we need to monetize it. So in a nutshell, the ultimate vision and mission for Solve.Care isn't just a vision, it's a reality. We have the platform. It reached that point of maturity this year where I can say, yes, we bring the right abilities of Amazon, the right abilities of Visa, and the right abilities of Salesforce in one single package to healthcare at a price point that anybody can afford. So this is about the best we could have hoped for. Now we got to monetize it. Now we got to go big. So the focus here is the great heights that we had aspired to is now within grasp. Not easy, never is. A lot of issues and challenges lie ahead, always will be. But where we stand at the best possible moment in time to launch Solve.Care platform in the market for the greatest possible good. So that's my answer to platform and product. Can health security, which in this case has to do with patient data security, be guaranteed to Solve.Care's approach? So this is a broad question. First, you got to think about data security, not just patient, but also provider. So patient data security is critical, but so is provider data security. And further, it's not just data, but it's also identity. So what are we really trying to protect? Let's step back and ask the question, who needs to be protected and what needs to be protected, okay? Because we talk about healthcare regulation all the time. And I find that people really don't know what this regulation is about. So what does the regulation and security actually mean? First, the patient data is important in that it not be shared with anybody who has no reason to share with, but the patient data is critical to be shared with a lot of people because that's what it is needed to happen for care to be delivered. So the problem with patient data security is not really patient data security, it's about patient data sharing and knowing who got it and why and for how long and what are they doing with it. See, we can build a big, huge Fort Knox type of a system that is impenetrable, stick all the patient data in it. Nobody can see it, nobody can touch it. It's wonderful, it's secure like unbelievably. And then what? What kind of care are you going to get if nobody knows your prescriptions, your past medical history, or your blood test results, your BMI, or your A1C, or anything? How are you going to get care? So the question of patient data security is patient data sharing, because you got to share the data with the doctor and the nurse and the pharmacist and the pediatrician and the oncologist and the endocrinologist, and you got to share it with the billing systems that can bill the insurance company, and everybody needs to know what they need to know. The thing is, not everybody needs to know everything. So we got two extremes here, and everybody thinks black and white in healthcare, and it's not really good because it's not really real. Either we talk about locking up all the data in Fort Knox and nobody gets to it. That's useless because it's no longer patient data. It's just medical records with no value. Or we talk about giving it to some party, one big giant system somewhere, like an electronic medical records, be it Epic, or Cerner, or McKesson, or Athena, or Allscripts. And then we hope that that big, massive aggregated data store is somehow protected, well-managed, honorably used, auditable, and so on and so forth. And 99% of healthcare regulation is written around that one trusted party who we don't know, I don't know why we think we can trust them, but that so-called assumed trust party, we then say, let's regulate the heck out of that party to make sure that party is not abusing your and my data. But that's really wrong too, because you're giving up all the control to this intermediary who economically is not aligned with your best interest anyway. Other than being good people and being morally correct people, you can't audit what they are doing behind the scenes. It's a silly idea. Let's give somebody unlimited control over our data, and then let's trust them. And then if we don't trust them, let's regulate them. So either we trust them or we don't. And if we don't trust them, we regulate them and then we audit them. And all along the way, we don't really have any visibility into what they're doing with your data. So this whole thing is ridiculous. Now, what are we doing? We are saying, let's make the data sharing easy. Let's allow the patient to actually view and control their data. But that doesn't mean the patient cannot share the data. In fact, they should be able to share it. But in sharing it, you should be able to maintain a chain of custody. Meaning that just because I sent you my medical record card doesn't mean you have unlimited power to do whatever you want with my card. You're a doc, you can see my card. Maybe I'll let you share it with a specialist. But you can't just distribute it all over the place. And if you do, I'll know about it. So the patient data security is more about protecting chain of custody and ensuring the chain of custody is not broken, and that we have auditability along the way as to where, what, who, when, how the data was seen. So that's one side of the equation. The other side of the equation is the provider data security. Now let me run a question by you. People ask me this question all the time. Hey, are you GDPR compliant? Can a patient on Solve.Care ask you to delete all their information? And I always ask, let me ask you a question. You go to the bank, you withdraw $1,000 from your bank account, then you invoke GDPR and say, bank, delete all my bank information, including this transaction. Forget the fact that I withdrew this $1,000. I want you to forget about me. Excuse me, you took a loan for $1,000 and you want me to delete all your information and forget about the fact that you owe the bank $1,000. Yep, that's my right. I'm invoking GDPR. I want you to forget about me. That's illogical. There would be no commerce in the world if you could just simply say to the other party, thank you for providing me a service, now forget about me. And forget about the fact that I owe you money, because I have the right to be forgotten. You don't have the right to be forgotten if you're in a transaction with a third party where you have mutual responsibility and accountability and obligations. So in healthcare, both sides have obligations. The patient has an obligation to the doctor has an obligation to the patient. Those obligations are clinical, data, identity, and financial. So we allow for all that to be audited, managed, and consent-driven. In this care platform, you can easily author who's responsible for what, who can share what, who can see what, who is able to share what, and who's going to then pay for what, and so on and so forth. And no, you can't just say, thank you for giving me a $1,000 loan. Now, please forget about me and delete all my information. That's not GDPR. That's simply illogical silliness. So what we are doing is allowing for the multi-step transaction between multiple parties, A, B, B, C, C, A, to exist and to follow the rules of the protocol, and to do so without unnecessary sharing or visibility into data. If A shares data with B, that doesn't mean C can automatically see data that A shared with B. C has to request permission from B or A. And in our case, the owner of data being A, even if B forwards a card from their wallet to the C's wallet, if A sends the data to B and B shares a card with C, C can't see that card. C is not able to view that card at all. C will still have to request the permission going back to A. Isn't that beautiful? Nobody can take your data, forward it on to anybody else, and the other receiver, whoever their data was forwarded to, opens a card and the card is blank, saying, you got to request permission from Pradeep. You can't see the card in your wallet. That's chain of custody. It's amazing. Hasn't been done before. Can be done in a centralized data model. Cannot be. Cannot be, because in the centralized data model, there's an entity sitting there, D, feeding data back to A, B, and C and deciding who gets to see what. And A has zero control. And this D, be it EMR or be it claims adjudication system or government agency system, is the god of all data, but it always has the data wrong because it doesn't actually talk to A that much. So the reason A, B, and C are always unhappy with D is because D is always out of sync. D doesn't know what patient is taking for prescription. D doesn't know what the doctor just did. D doesn't know what the pharmacist just did. D is trying to stay in sync with everybody. D is always out of sync with everybody. And no wonder we are always pissed off at insurance companies or at government agencies, because they are always looking at information long after it ceases to be meaningful. So the whole idea is, don't rely upon D. There is no need for D to be this god of data. A can send data to B, and B can share with C, and C can ask for permission from A, and A can grant the permission, and everybody is in sync all the time. And yes, if D really needs to know something, we can let them know as well. We are flipping everything upside down, because the only way to solve the healthcare issue is to rethink the healthcare data sharing. We cannot fix what is so fundamentally broken. We have to reimagine the way it should have worked from the day one and the way it can work now with blockchain. This brings me to the question that I get asked a lot. Could you do this without blockchain? The answer is yes, but not easily, and certainly not affordably. Everything is possible. Warren Buffett said, if you give a fool $1 and give him enough time, through simple compounding of interest, in 100 million years, it might become a billionaire. The problem isn't that you can't reach there. The problem is you won't live long enough to enjoy the benefits. So we need to make things efficient and fast and make them happen. And blockchain helps us get there. Yeah, you could do all this with probably some very convoluted system that nobody could afford or configure or buy or run. So theoretically, we could do a lot of things, but we never did because they were commercially unviable. Blockchain makes this incredible peer-to-peer chain of custody of data possible at a much more affordable level. Therefore, here we are. This is why the security and data in healthcare, in Solve.Care platform is different. So how are we different in a nutshell? First, data is deaggregated. Every wallet has its own vault. Second, data sharing is consent-driven. And third, that chain of custody extends from A to B and B to C and C to D. That chain of custody never breaks in the system, which therefore makes it possible to control every single participant in the care to have the right information, the right time for the right duration. Hasn't been done before. Certainly not at any scale. Maybe in a lab at MIT, but that's not what's going to be used inside a hospital. Our platform will be. And that's the difference. So in a nutshell, answer to this question is yes, we are very different. And yes, we guarantee it. Next question. Devices in the platform we call care devices to make it unique for all the devices onboarded, to make it peculiar to the platform is something that can be considered. It's a good idea. Our care dot concept is quite clear, and it has been used for care cards, care protocol, care wallet, care journeys, care networks. And what we have done is we have created a concept of care data. Now, the reason we chose care data over care devices is the following. Devices are a source of data collection. Why do you need a device? Well, you need a device to collect data. Okay. What if the data is not coming from the device? Well, that's still care data, and it's very important. So what we thought was the purpose of the device is the care data, and let's focus on making care data that much more intelligent and easy. So we have designed a standard care card called Care Data Card. And the Care Data Card allows us to collect data from devices or from even third-party systems like EMR, like EHL7 feeds, FHIR standards. And the idea of a Care Data Card is to say, what do we really want from the device? What do we really want for a patient to get better? We want real-time information. We need these values to be received from a trusted source. We want these values to be referenced and contextualized and relevant to the care network and the care journey. So we designed a Care Data Card. So essentially what happens now is that a device that connects to care platform delivers a Care Data Card. Cool, simple, easy to understand. The device's job is to generate and send a Care Data Card to your wallet. Now, whether you're connected to a CT scan, which you can take home, but it's a big, gigantic machine that you go sit inside and generates a bunch of data about you, or it's an MRI, or it's a EKG, or it's a home EKG like a LiveCore, or it's a Omron's blood pressure monitor, or it's the upcoming continuous blood pressure monitoring system that we are integrating, or it's the Ring. Whatever the device is, the purpose of the device is not the device itself, but the data it generates. So a standardized care data card that arrives in your care wallet, gets linked to your care ledger, and gets stored in your care vault is a beautiful thing. And that's what we have done. So yes, it's a great idea to use a care.device concept, but I think it's more appropriate to think of it as a care.data concept. And that's coming up in a soon to be released version of Care Wallet. So I'm very excited about that. Let's talk about interoperability. This is a long question, but I only need to read the first word to say that I like this question. Interoperability is the greatest issue in healthcare, and a platform that solves this will be the bedrock of healthcare and also the greatest selling point. Can we explain in detail how interoperability will work in the platform? Is the platform not powerful enough to have interoperability between, say, 100 different networks? And please explain in detail the system and architecture that is in place to solve this and ensure that full and very adequate interoperability between cards, journeys, wallets, network systems, and the platform without any issues or data security concerns. Well, that's sort of like throwing the kitchen sink at it and saying, have we solved every problem in healthcare? And are we now ready to be a $1 trillion company? Because we could go public tomorrow on New York Stock Exchange if I answered yes to everything. And we would essentially be rivaling Tesla without any of the problems. The answer is we are on our way. We have done a lot. But let me break it down. Interoperability is indeed the greatest issue in healthcare. But the interoperability as defined in healthcare is fundamentally ill-defined or misdefined. The way interoperability is defined in healthcare today is the following. Does the doctor's EMR talk to the insurance company's claim system? Does the pharmacy system talk to the doctor's ERX system? So for every relationship that's possible in healthcare, AB or BC or CD or DA, there is an interoperability layer being custom built for that. So let's say A is a doctor, B is a patient, B is an insurance company. So you got to have an EDI gateway or an EMR gateway between A and B. So we go and talk about interoperability, and we build all these custom bridges, and we give them fancy names like HL7 or XR12. But guys, you're just building one bridge between A and B. It doesn't do a darn thing for B and C, or C and D, or D and A. So this is the problem with healthcare. We are always building a peer-to-peer pipe between A and B, or B and C, or C and A, and we're declaring it to be interoperability. All it is a data sharing pipe. Big deal. What have we actually accomplished? Have we made A, B, and C interoperable? Forget that. We get into HIEs, and HIEs are a massive investment, and they are government run, and it takes them years to launch and even decades to become financially sustainable. And all they do is they get from AB to ABC. So interoperability is all fundamentally a nonsensical concept as defined in healthcare. The real interoperability is any to any. The only real definition of interoperability is any to any, not A to B. A to B is a pipe. You could have just hired a bunch of couriers and run data between A and B, which is kind of what today happens. Yeah, we run a bunch of data, but we're not a whole lot different than SneakerNet or moving tapes between systems, which is how data used to move a while ago when the computing was mainframe based. We're not that far away from that concept. So interoperability between two defined parties is not interoperability to begin with. It's just a pipe between two parties. And those pipes serve nobody else but those two parties, which is not interoperable to begin with. Interoperability should be any to any. So now, how do you make everybody talk to everybody? And that's where government stepped in when I was working on the Affordable Care Act, and we were building all these interoperability platforms, frameworks, and they had very fancy names, HIEs or statewide consortiums of data exchange, and EDI gateways, and this, that, and the other. The problem was that we tried to pull everybody together into a consensus-driven model where everybody had to agree up front on who will share data with whom. Well, guess what? Nobody agrees on anything. So as a result, even though we built any-to-any centralized platforms or gateways, nobody used it because you had to actually define the any-to-any upfront. It was really you to me to the doc, and everybody had to agree that this is what we're going to share data with. It's not ad hoc at all. It's not peer-to-peer. It's literally just a huge morass of multiple pipes connecting it to everybody. It's as bad a spaghetti bowl as you can ever imagine. So no wonder billions went into interoperability and nothing came out, okay? Now, what is our vision? And what have we done? We have said, no, interoperability should be thought of as a pyramid. And each pyramid layer should talk to every participant in that layer and across layers. But for each layer to bridge to other layer, there has to be certain rules. But within each layer, data should be ad hoc, meaning we can move data between A, B, C as long as you share a layer. So what does that mean? At the bottom of the pyramid is Care Wallet. If I have a Care Wallet and I can join 5 networks, and those 5 networks become interoperable by the simple fact that I joined them. And those networks do not need to know anything about each other. They only need to know that I have joined that network. And every network only needs to know that I've joined that network. But when I join that network, A and network 7 and network X and network ABC, these networks become interoperable by the simple fact that I joined them. That's magic. Because interoperability only matters to me if what the data I need to share with the parties I am interested in or who are interested in my care are interoperable. I don't care about the fact that there are 2 million other providers on the planet who can't see my data, because they are not going to take care of me. So why should I care, and why should they have access to my data? Interoperability for me is interoperability for everyone who takes care of me, right? So interoperability is not an abstract concept. It's a very finite concept. It requires me to get the best possible care by getting all the people who are giving me care can talk to each other without knowing anything about each other. That's interoperability. So that's Care Wallet and Care Cards. The second part of it is, well, okay, how do I get the parties who are working with me inside a care episode or a care journey can talk to each other? That's a care network. So we make interoperability configurable inside the care network by allowing any wallet in the network to talk to any other wallet, as long as those wallets are not regulated to prohibited from talking to each other, because you may have a scenario where certain interoperability is bad. You don't want the doctor to share my information with my employer, even if the employer is paying half the bill. Employer's job is not to know about my health conditions, and the doctor should not be able to send my data to the doctor or to the employer. So interoperability should permit data exchange, but also should protect me and regulate who exchanges what data. So Care Network and Care Protocol give me that confidence that my data will be protected and only be shared between my doctor and the specialist, not with my doctor and my employer. And that's where we get into the Care Protocol and the Care Network concept. So that's interoperability, but governed interoperability. And then you get into the third level of interoperability, which is interoperability between systems, which is what everybody's been chasing all these years. That how does a care network between Solve.Care, Care Network, and a third-party system, such as an EMR or such as an EHR or a hospital information system or a ERX or my employer's wellness management initiative or whatever that's going on. And there's a ton of other systems that I don't even want to know about who need to connect with the care network. And that's the traditional data exchange through EDI and HL7 and custom interfaces. And there, our secret sauce is the community, to say that we will allow you, starting in 2023, to start extending the care platform to connect to every system in every part of the world. But here is the kicker. If we do the first and the second layer of interoperability properly, which we have done, the wallet and the network, you don't need the third layer as much as we do today. We're starting with the problem in the wrong end of the spectrum. We're starting with the problem with system-to-system interoperability, which is exactly the wrong place to begin. If we have patient-centric interoperability and if we have network interoperability, then the vast majority of the use cases that exist in healthcare would not need the system-to-system interoperability, certainly not at the level we need it. So we're solving the problem that nobody has ever solved, and they're always solving the wrong problem, including me for the last 3 decades, and Solve.Care is solving the right problem. Patient-centric interoperability, network-centric interoperability, network-to-network, inter and intra-network interoperability is where the real value is. And then when you get into the more traditional system-to-system data exchange, those are just pipes, guys. They're not interoperability. Stop calling it that. It's just a to B connection. And there are a million ways to do those connections today. There are millions and millions of companies and people who have built these pipes already. Use them. There is no new value to connecting another instance of Epic to another instance of TriZetto. It has been done 30,000 times. And you're not going to add any more value of building that pipe one more time. This is just pure insanity and waste of money. So we believe that system-to-system interoperability, to the degree it actually exists, it's already built in the context of existing pipes, and new pipes can be built easily. That's not where there's any magic. And frankly, none of those work that is going on for the last 30 years is interoperability. It's just connections between 2 points, and those connections exist. So what nobody has done is what we are doing. The bottom of the pyramid is a wallet. The middle of the pyramid is the network. And the top of the pyramid is this block of code that everybody's obsessing over. So we do the 2 things that nobody else does, and we accept the fact that the world has done plenty of the third tier, and we will use it. We don't need to rebuild it. Having said that, can 100 different networks talk to each other? Well, listen, if you are sick enough to need to connect to 100 different care networks as a patient, then every one of those networks will talk to every other network. I hope none of you ever have to join 100 networks to take care of yourself and your loved ones. We think that an average family of even 5 or 6, let alone 4, the nuclear family or the extended family of uncles and aunts and grandparents and grandchildren, you would need a dozen networks in your life. If you're really sick, maybe 15 networks, 18 networks, and you won't be active in all of them at the same time. So no matter how many networks you join, they're all going to be interoperable because they're all connected to your wallet. They are already. However, there's no need for you to be worried about a doctor in Zambia that you will never, ever, ever see. And you don't need to be interoperable with that doctor, even if you could be. So that's my answer there. It's the same question again. It's not the number of networks that matter, it's what networks you join and that you care about that matters. So whatever you join, it does become interoperable inside the wallet. And whatever the network participants are, they become interoperable inside the network. So it's a funnel. That's why it's a pyramid. The wallet is any to any. The network is network to network and intra-network and inter-network. And then the system to system is the traditional pipe system that has existed in healthcare. And frankly, does a very poor job, but it's necessary and we will use it. We don't need to reinvent that wheel. So the next question is the technical roadmap for Care Wallet and Care Labs in the time frame for the website revamp. So yes, we have the Care Wallet roadmap. We worked on it for the last several months, actually, and the Care Labs roadmap is being developed as we speak. I do not have the website revamp roadmap from Maria yet, but what I can say to you is that we will publish the Care Wallet roadmap before end of the year. We will try to publish the Care Labs roadmap as soon as, well, not try. We are working on publishing the Care Labs roadmap right after Care Wallet, but I will need a bit more time for Maria to come back with the website revamp and upgrading. Personally, I would like to see it done in Q1, but of course, we have a lot of other competing priorities. So let me say this, that you will have the Care Wallet technical roadmap before the New Year holiday, before December 31st, and I'll publish that. The other two, we will publish in Q1, but we'll do our best to publish it as soon as we can. That's about as definitive as I can be, because Solve.Care is really facing an enormous backlog of customer and very exciting things that are coming up. So I don't want to reveal too much here as to what's happening, but I will say this, that I accept the fact that the team has their hands full, and we will come back with the website revamp as soon as we can make that a priority. The good news is this, our website does not reflect anything as to what we do today. We have so outgrown our website. It is so dated that it is not even close to what Solve.Care is capable of today and what value we bring to market. That's the good news. And you're laughing and going, why is that a good news? The reason it's a good news is that our clients don't care. We are signing clients at a fantastic speed. And they're not buying from us because our website is great. They're buying because they love what we do. And they're hearing about us from other clients. Now, obviously, we need to fix the website to reflect the reality of who we are, how far we have come. So many other clients that we haven't signed would sign up. So there is no doubt it needs to be done. But we know that despite the website being out of date, we are starting to make our mark in healthcare exactly as I had hoped for. So in a nutshell, Care Wallet roadmap before end of the year, Care Labs in early Q1, and I will ask Maria to answer the question when she can have the website revamp roadmap ready and published for you guys. This is an interesting question about Deltec. Deltec is one of our financial institutions. I would rather not talk about our financial arrangements, but in a nutshell, we manage our banking relationships as we see fit, and we do not want to publicize which bank is or is not currently serving us, but we do have a number of banking relationships around the world based on the jurisdiction. There is Solve.Care USA, there is Solve.Care Korea, there is Solve.Care Hungary, there is Solve.Care Estonia, and each of them has appropriate and separate banking relationships. Okay, let's go to the next one. 3 months to get started. Okay, you're talking about the city vendor here. So yes, we got certified as a vendor. It took a lot longer than I had hoped for, but I also know government works slowly, so it's not a big surprise it took this long. The next steps are, we have already conducted the other steps in parallel. So now where we get into post-holidays with them is what we call the Care Labs workshop, where we sit with them and we design one or more care journeys. And we take that design using the care journey board. We author the journeys, we send it to them, they take a look at it, then they will provide several rounds of feedback. And after those journeys are authored, then they will launch a test program to see a few hundred citizens or a few thousand, it depends upon them. And once that's done, they'll gather more feedback, they'll re-author journeys, and then they'll have to go through their formal procurement process. So this is a process that typically is associated with the government agency or a government procurement. But in a nutshell, we have reached a point where rapid engagement with a client is now possible. Where that goes in terms of how fast they can go from engaging to launching, it's hard for me to say. I've been on their side of the table. I have done these kind of procurements, and I know how much risk and activity levels I need to do to cross the T's and dot the I's so my procurement doesn't fail at the last step. In government, if you hurry, you repent at leisure. So they have to make sure that everything is done correctly. Here is a real question, though. Why not multiple government and why not multiple cities? So we realized after we had these conversations in summer, in June of 2022, that what they are excited about, other people are going to be excited about as well, other cities. So we have started to expand our target focus on various different cities, not just one. And I think that in 2023, we will see more than one city launch our platform for citizen engagement and citizen services. Which one will go first? How long will it take? I do not know, but I do know that we have reached a point where we can expect more than one client of that ilk to be launching the platform. And there are multiple conversations and workshops underway. We're not just talking about chatting, we're talking about active workshops being scheduled with government agencies in various different jurisdictions and city and county and state organizations saying, hey, I want to use the platform now. This is very exciting. Can we give them a roadmap? No, that would be unwise. First, they will never allow it. Government doesn't want to tell you what they're doing, especially if it's procurement related. It's very sensitive. There are lots of rules governing it. If you're going to get sole source, if you're going to get run through an existing contract, an IDIQ, or if you're going to be, IDIQ stands for indefinite duration, indefinite quantity type of contracts, are we going to get sourced through a set-aside program like an 8A or a disabled veteran-owned enterprise? There are many vehicles, and the government typically tells you what vehicle they want you to use. So none of that should be roadmapped out in advance. That's super risky, and they won't agree to it anyway, and why would they? So what we will do is to tell you as much as we can, but I can tell you without compromising any single entity that we have multiple government agencies and organizations and jurisdictions that are looking at Solve to build citizen-centric solutions now. Okay, so we switch to Definitize now. All right, I'm very excited about Definitize, guys. I always was. In 2022, we had to put things on hold for a variety of reasons, but I'm really happy that we did, because with the release of the new platform, we can do Definitize a lot better than we could have done before. So there is a very simple reason to get re-excited about Definitize, and that is that the platform allows us to launch Definitize at a much more cost-effective and in a much more auditable, traceable, and community-engaged way than we could have done before. So putting Definitize on pause was a good thing. I didn't know that it's a good thing. I was pretty unhappy about it, but it was the right decision to make. Sometimes you make tough decisions, even if you don't like them. And Definitize and GTHE were those two decisions I had to make in 2022 that I truly hated, but I felt that that was the right thing to do. So we did. And I'm really glad that we did it, because now I can see clearly a pathway to launching Definitize and GTHE. We'll talk about that in a minute on the platform with authored on-protocol networks, which make it so much easier to do magic. So now let's get to Definitize. So the minimum threshold has been reached. Yes, absolutely. Congratulations, everyone. And thank you for whoever stepped in and mined the tokens, because without that, we would really not have broken through the glass ceiling. And while the mining was going on, the platform was being matured enough to do things that we want to do in Definitize. So this is great. Has Solve.Care mined it? No, it wasn't Solve.Care who did the mining. Did somebody at Solve.Care mine it? I wouldn't know. We don't ask that question from employees. That's their own business. Definitize is a DAO, it's a decentralized autonomous organization. We don't want to have influence over it unnecessarily. Our job is to make it happen, but not to run it. And we certainly will not incentivize or encourage or discourage people to do what they want to do. Having said that, yes, it has been mined fully by the community itself, and we are very excited about it. The second is, do we stop anybody from mining Solve? No, of course not. I mean, you can mine DCare by staking your Solve, any one of you. Why would we interfere with that? And Definitize is not really run or owned by Solve.Care to begin with. It's a DAO that we want to enable in the market. So that's the answer to that. But there are a few more questions here that are not asked that I want to answer them. So now what happens? So there's one thing that Solve is looking at doing, and we have a call on this tomorrow, on whether we should mine DCare, and if we mine them, what to do with them. And I'm going to make a proposal to the team and to the board that we should mine DCare, certain amount, not huge, but meaningful amount, by staking Solve, and then donating those DCare to the treasury. And by doing that, we are effectively supporting the Definitize community to go and achieve its mission and to show our support for the project. So that's one thing. It's not decided. We will let you know if we decide to mine. This is not going to be some secret. But it makes sense because we would love to have the Definitize community have DCare in the treasury that can be used to build and Definitize forward. And from Solve.Care perspective, it's just a good thing to do. And it has real ramifications for healthcare down the road. So that's my thinking. It's not something that we have decided, but we will contemplate this, and we may mine a certain amount of DCare using Solve tokens with the intent to donate those DCare to the treasury itself. So that's where we are from the mining point of view. Let's stay with Definitize. My vision for Definitize, there are several questions about Definitize, and Kevin does a really good job of asking these questions. Unfortunately, there are no good answers. Questions are brilliant, the answers are not clear. Definitize as a DAO will have to be subjected to whatever regulatory environment DAOs will ultimately be subjected to. And like token sales in the 2017-18, nobody knew what they are going to be, but it was clear that the most likely scenario for ICOs is to be treated like an equity sale. And if you proactively and preemptively follow all the rules of equity issuance, then you're probably going to be okay because you're not going to do bad things. You're going to follow the rules. So be self-governed, guys. When you don't know the answer, be conservative. It's good to dream big and innovate, which we always do, but you also got to make sure that you are doing things to keep everybody safe. So my view is that the DAO organizations, even though they're fully decentralized and autonomous, will need some kind of a regulatory framework. And if you think about the logical framework for a decentralized autonomous organization is to have some kind of a governance model, which then answers to the authorities. So a fully decentralized community could do a lot of things, but it still has to prove its compliance with jurisdiction that will come to pass. So we need to think about, and Definitize is designed to have a governance model. It's not a completely governance-free framework. It has a governance committee, which means that the governance committee is physical people with physical skills to do things and to answer for things in a manner without necessarily accepting responsibility for the community actions. So there is a split between what the community decides to do and what the governance is responsible for enforcing the decision in the real world. So that governance committee model, I think, gives us the ability to effectively operate like an organization where the board of directors is a vast number of people and they vote on everything, and then whatever they vote on is enforced by the governance committee, because that human interface, that real world interface, is missing in many DAOs. So that structure being there, I believe that Definitize is a feasible concept. But I don't have the crystal ball to tell you, Kevin or anybody else, as to where the regulatory chips will fall. But we can be sure that if we demonstrate a compliance mechanism, if we demonstrate a governance mechanism that we self-adopted that effectively protects against bad behavior and exploitation and misuse of people or their funds, then we should be all right. But by the letter of the law, we don't know which letter of the law will apply. So end of the day, Definitize has to think ahead, be forward-looking, be conservative, at the same time being innovative, and it should be structured such that we can answer to regulatory bodies when they come calling down the road. And if we can demonstrate intent and purpose and execution in self-governance, then end of the day, we'll be the one of the few DAOs that will actually be allowed to exist and survive and to grow. So that's our thinking on that. Last thing is that now that the platform is authorizable at a fantastic speed, let's build Definitize as a care network. Solve.Care will make the platform available to the Definitize community to use. We will support the Definitize community by running workshops and helping the community think through how to author Definitize as a care network on the platform. Care Wallet is already free and in the App Store, so you can use it to access Definitize Care Network. There's no cost on that. The DCare as a token has already been mined, so really the only thing left now is to come up with the Constitution, the Governance Committee, and the Care Network. Those are the three big milestones for Definitize now. That makes it very, very possible to do it in the next year. I'm not saying it's done, but I'm saying that if you focus on those three things, get the Constitution adopted, design and author the Care Network from community resources, and make sure there's a governance committee in place that can physically govern the real world implications of Definitize, and we should be able to launch. And not only launch, but actually make a difference in people's lives. So I am super excited about Definitize, even though I don't know all the answers, because I see a path forward. And my philosophy is, when you're roaming around in the jungle with no path forward, it's very scary. But when you see a path, take it. And then along the way, you may have to detour around stumps and rivers and valleys. But as long as you know which direction you're heading, where the sunlight is coming from, you will get out of the forest and you will get into the sunlight and you get into the meadow. So in a nutshell, I see a clear path forward for Definitize in terms of which direction to go. But I don't have every single step mapped out because nobody can. But with the community authoring the Care Network on the platform, with a constitutional adoption that can now happen, and with a governance committee that we need to elect as soon as possible, we think Definitize will be one of the few, if not the only, real-world example of DAO being used in a meaningful way across a real imminent set of needs and a lot of geographies. So with that said, let's get Definitize back on track next year, and let's focus on what we can do. And let's avoid things that we shouldn't do, and let's not focus on things that aren't possible today. Let's design the Definitize model to be relevant, usable, launchable as a care network with a governance committee in place per the Constitution that all of you will vote to adopt. All right, and let's go to GTHE. So I'm same as Definitize, I'm very excited about GTHE. Now, we spent a ton of time and money on GTHE, a ton of time and money. And as you may remember, we have signed hundreds and hundreds of doctors in many countries to participate in GTHE who continue to be interested. But as we started to launch GTHE across different disease conditions, we realized that as a standalone GTHE product, which is not on protocol, there is no reasonable way for us to build disease-specific, physician-specific, jurisdiction-specific, or patient-specific care journeys, in which case we become yet another system that promises a lot, but is ultimately financially and economically and clinically unsustainable, and that we're gonna need to raise a ridiculous amount of money. And this, as a standalone business, would look like a Teladoc or like American Well. And there's a great companies that do great work, but that is not who we want to be. The last thing you want to be is a one-trick pony selling telehealth in a way that works in the US but doesn't work for Canada, and works in Canada but doesn't work for UK, and everything is custom coded and everything is built with somebody's vision that everybody else has to adopt. This is completely the wrong thing. Absolutely everything Solve.Care should not stand for. Solve.Care stands for open health. not another siloed health. So I stopped GTHE once I saw it working, and once we saw doctors using it, and the request started to come in with, I want a care journey that is specific to my specialty or my patient group, and we realized those journeys can only be authored on protocol. They cannot be authored off protocol. So yes, GTHE was stopped because what we want to build is an open GTHE, not a silo GTHE. And then we put all our focus on ensuring that the journeys can be authored. And today we are at a point where we can reimagine GTHE as an on-protocol network. So we still have the docs. We have a growing number of Care Wallet users, but the docs are there. The journeys we need to make physician-led rather than Solve.Care led. And GTHE should be built as an on-network, on-protocol network with full interoperability between all the journeys. And that cannot be done manually. It has to be done systematically by the platform. So we put a pause on all the appointments. And in fact, if you talk to Salute blockchain, they were very disappointed because we were getting a lot of traction, and all our initial tests and initial consultations were happening in Latin America. And they had, Felix and Danny and others are working very hard to bring in these doctors who were now starting to say, but I want this journey and I want that journey. So I had to essentially stop a train that was already rolling on its tracks because I realized the tracks were headed in the wrong direction. We re-engage on that front. Next year, we pick it up and we re-author it, or we author GTHE rather, instead of building it. And that makes it much more feasible as a global platform rather than another point-to-point solution. So that's where we were. Now, your question is, what does control setting means? It means control setting, where we handpicked certain doctors and gave them the GTHE wallet. We allowed them to invite certain patients to the platform and interact with them and do consults and exchange Solve tokens, and that was all fine. But the problem again was these journeys that we needed to develop for the physicians or specialists were all off protocol and they were not interoperable, which means that we might have picked up traction just on GTHE as a narrow teleconsultation platform. But once people got going on it, we would have never been able to replace it with an on-network protocol. We would have had to have a complete and unimaginably complex transfer of data and tokens and identities from off protocol to on protocol. That was not possible. Raj and I talked about it. It was clear that if we go full scale with the off protocol GTHE, it could not move to on protocol without significant risk to people's data and their identities. And we didn't want to take that risk. So long and short of it is that GTHE physicians were already starting to transact with patients in Latin America when we shut it down and said, no, this is a dead end. This is not going to go to any kind of a global impact. And we could see revenue, but it will be non-profitable revenue. We could see significant revenue, but that will only mean that we will lose money faster. And we needed to stop and re-pivot to a platform-based GTHE. So here we are. The platform is at a point in time where GTHE can be and will be authored as an on-protocol network. And we will launch with not just a list of doctors we already have enrolled on GTHE, but certainly a much broader list of physicians that we can go after when we tell them that they can actually author their own care protocol or care journeys on the platform on the GTHE care protocol. So that's where we are. Okay, Korea. Korea is ranked 6th here, visualcapitalist.com, most innovative. I've looked through that list. If Korea is to move up the ladder, in what way can Solve.Care help them achieve that? It's a very interesting question. It's a brilliant question. First, Korea is ranked 6th most innovative countries, but not in healthcare. Korea is a very good healthcare system, but it's not innovative in the least bit. It's actually very rigid. But if you compare the healthcare systems, while Koreans get excellent healthcare, no doubt, the system is very, very rigid, and the government recognizes that. And the government of Korea is now starting to rethink how healthcare needs to become made more innovative. And people like Dr. Lee, our president in Korea, are challenging status quo in Korea in healthcare. So while Korea produces great phones and great electronics and great cars and great tanks and great fighter planes and great emojis and great pop stars, they do a lot of amazing things. but healthcare is not an innovation center for them yet, but it's happening. So our vision is to make Korean healthcare work better, serve Koreans both in and out of Korea better, and to be more effective, not just in delivering care, but getting better value for their care. So we, and as a Solve.Care, are investing heavily in Korea, not because I like Korean food, I do, and not because I love Dr. Lee, I do. But the issue here is that Korean healthcare is ripe for innovation, but there's nobody who's yet stepped up and shown them the way. And if you were to look down the road, 2-3 years down the road, Korea is going to pivot to a much more innovative, much more home care and online care model. They may not focus on teleconsultations, but they'll focus on a lot of things like access and quality and second opinion and home delivery and home care and home data monitoring. There's tons and tons and tons of things that Korea can and will do, in our opinion. Plus, insurance companies are going to step into more providing incentives for managed care and providing disincentives for not taking care of yourself. You see that coming from a mile away. So all that is going to happen in Korea. We are going to continue to be in Korea and invest in Korean healthcare system, not just the way it is today, but really the way it needs to go. And I'm not even counting on the really sexy stuff like metaverse hospitals, which I will come as well. I'm talking about the fundamental shift in healthcare where insurance companies, employers are both incentivized and penalized for not helping their patients or their employees take better care of themselves. That's a seismic shift. It's coming, and we intend to be right there, because that's what I did before in the US. And that's where we see Korea going. And we will work with not just the Korean government and Korean hospitals, but even other thought leaders and innovators in Korea, companies who want to make things better and who are innovating on a massive scale, but they have no place to go today. So in a nutshell, here is my answer. Korea is very innovative, but not yet in healthcare, but it will be. We understand the long-term picture, and we are investing in it with an eye to the future. And we think that our value proposition to Korea is both clinical, administrative, and financial. But most importantly, it's about enabling different care models than the hospital-centric care model that Korea has. And we are seeing traction when we clearly define our value proposition. And we don't try to change their laws, but we try to work with the laws that they already have. And we find innovation opportunities inside their current regulatory framework while helping them rewrite the regulatory framework over a course of half a decade to a decade. That's how long it will take for their regulatory framework to change. But in the meanwhile, we can do a lot of things in terms of patient engagement, remote care, second opinion, and home care, and so on. And those opportunities are perfect for Care Platform and Care Wallet. Korean roadmap shows we are supposed to have 6 new partnerships. And yes, we told you we'll have 6 partnerships. And yes, we will have 6 partnerships by end of the year. Nothing more to say. Stand by for announcements. We were really excited when you said the protocol will be enhanced, or rather has been enhanced, so that a network can be authored in 1 week instead of 1 month, a journey in a day, and instead of a week, and card in an hour. I said, this is where my goal is. I want to get the protocol to that point. And I will say this without telling too much, that we're making strides in that direction. And it's not just the speed, it's also the ease. So an enormous amount of work is being done to achieve exactly that goal. But even card in a day, journey in a week, network in a month is pure, unadulterated magic. We don't need to get to a card in an hour to own the market. The goal here is not some arbitrary deadline. The goal here is ease and low risk and low cost of authoring a card, journey, and network. And we are already there. We're already able to meet and exceed client expectations. But I want this to be faster. As I said in the previous AMA, the faster we can go, the lower cost and lower risk it is for the client to fail fast, learn fast, grow fast, adapt fast. It makes sense. But in itself, it means nothing to the client, because they can give us journey requirements faster than a week anyway, even if we could do a journey in a day. But it just does mean that we can run that many more parallel client authoring sessions. So it's a great goal. We will get there in 2023. There is no doubt about it. The progress we have made is stunning, but I'm not going to commit to a time frame when this is possible, because it's coming and it's going to get done. But either way, our clients are more than satisfied with the speed of authoring that we are currently showing them. And frankly, we are 10 times faster than they can currently support the journey authoring process. So it's a great focus. What I would add to this goal is also to say who can author. And I think that's where my focus is right now, is to reduce the required technical skill and threshold of knowledge that is needed to author a card and a journey and a network. So we are well on our way, guys, to try to pick on this and say, when can you author a card in an hour, means nothing economically to us. It only means that we keep making things better. But is this going to happen in 2023? Absolutely. I don't have a fixed date, and it doesn't matter, because a fixed date is not important. The important thing is, are we serving our clients well? And we are doing a really good job of that today. Solve.Care has tried in so many ways to combat the 4 major domains: access, usability, risks, and benefits, privacy and security, and data management, and digital healthcare through introduction of care wallet, app, cards, and protocol, and so on. I don't see the question here. So probably the question was, here we go. Here's the question. But in the aspect of risk and benefits, which has to do with evaluation of the probability of harms and discomfort weighted against potential use of products, which could be physical, economical, or psychological. I'm sorry, guys, but I don't understand this question. So whoever sent this question in, can you please rephrase it? Because I'm not able to comprehend what you're asking me. So I will wait till this question is clarified, and we will answer it in a written format, so your answer gets to you before the next AMA. But please do resubmit this question. Thank you. Transition from Web 2 to Web 3 healthcare solutions will be a very hard task. And there are so many powerful, rich people, institutions, government authorities that will not be happy with Solve growth and development, and will fight and obstruct in several ways on Solve's plan to disrupt healthcare. What are your plans and strategies to fight off and manage these powerful people, organizations, and be victorious in the long run? It's a really good question, but it's a very abstract question. Let's be a bit more specific. People whose livelihood you threaten will fight you. People whom you benefit economically will support you, right? Pretty simple. Those who benefit from the Solve.Care platform will support it. And those who don't, or whose current hegemony or their current monopolistic position in the market is threatened, will hate us. So it be. The question is, are we delivering enough value to those we are targeting as our clients or consumers of our clients? We are a B2B2C platform. We are here to serve healthcare delivery organizations to deliver better healthcare to their patients. And we are making it possible for a single doctor in a small shop in the middle of a village to take better care of their patients, and to use the Solve token and the care wallet and the care cards to deliver better healthcare, get paid on time, and to connect that patient to the right care, even if it's not in the village, worldwide through a global network of networks. So this is the idea, and it's going to change healthcare for every single human being. And will some people get upset along the way? Absolutely. Because those who live on these pipes that I described to you, those who survive on an AB or a BC pipe, don't want to see an ABC pipe emerge, because it destroys their pipe system. So yes, that's going to happen. And yeah, they'll fight us. But the only way we survive and we succeed is that we deliver enough value to A, B, and C, so that they don't want to use the AB and the BC pipe. They want to use the Solve.Care platform for ABC peer-to-peer communication. So we rip out the pipes and we replace them with a platform and a network. Won't happen in a day or in a week or in a month, but we are already showing enough value to A, B, and C, where they are questioning, why do they need these pipes to begin with? We are working with some very marquee clients, names of which I will not disclose, but who are currently using the pipes as well. They are clients of all the big healthcare vendors. They are the client that IBM or Epic would love to have, or has had, or have today. And we went in there and we explained to them what we do, and they said, we love it. We love what you make possible. It was previously impossible. And let's start with a network, and if this works, we'll launch dozens of more networks. And that's one institution, one single client. So the point is, We don't need others to fail for us to succeed. We don't need those pipes to break for us to be successful. Those pipes can exist. Those vendors can do what they do today. We are simply we're solving the intractable problem of healthcare that they're not solving. That's our entry point. Over time, we may replace these pipes, but that's not our first and primary goal. And there is plenty of time to learn and grow. So the value proposition for Solve.Care is compelling. We're not selling against technology vendors. We're selling to the A, B, and C population and saying, you can do a better job of coordinating care, administering care, and doing financial transactions on our platform, and let's deal with your harder issues that your current pipes don't solve. But that doesn't mean that we are naive. We know that there is going to be disruption to many of the existing revenue streams in healthcare. And there are a lot of people getting fat and happy on the inefficiency of healthcare. And when we make healthcare more efficient, they're going to be unhappy with us. But that's true for everything. And I'll give you an anecdote. When I was a CIO at many health tech, large organizations, and this is before right around the time when iPhone came out, and I remember my chief information security officer telling me that we will never, ever, 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 ever allow Apple products to come into the enterprise. We are a Windows and Linux and Active Directory system, and our IT infrastructure is bolted down. I mean, it's ludicrous. I'm thinking back 20 years thinking our IT system was crap, but they were so proud of it. And they were never going to let a bring your own device, BYOD, or Apple products in the shop. We can't remote control it. We don't have this. We don't have that. It's not configurable. It's not customizable. It doesn't connect to Active Directory. It was all nonsense. But it was sold as God's truth. And I remember thinking, okay, so basically we're going to say that we're going to stand in the way of innovation because we feel that any innovation that threatens our IT infrastructure should be stopped. Well, Apple didn't really listen to people like me or my CISO. They went ahead and released the iPhone and the iPad. And here is what happened one magical day. I got a call from the chairman of the board. And he said, you know, my grandson just gifted me this really cool device called this iPad. And I love it. And I know that I have a board meeting coming up in a week or two. So instead of sending me that crazy thick binder that you send me every quarter before the board meeting, 600 pages printed in a beautiful folder and sent to me in 3-5 days before the board meeting, I don't want that. Can you please send me this whole board material as a PDF on my iPad? I want to flip through it on my iPad. Well, this is the board chairman calling. So of course I called my CISO and said, we're going to deliver the board book as a PDF. And my CEO is like, absolutely, we got to do what the board chairman says. So guess what? In the span of 3 days, all our policy decisions about how Apple devices will never enter our building, they'll never connect to our Wi-Fi network, we cannot allow Apple to be inside our Active Directory network. We solved all those problems in 3 freaking days. All right. And the board meeting happened with every single board member gifted an iPad by the company, and they were all browsing their board books and taking their votes on their on the board resolutions on their iPad 72 hours after we got a call from the board chair saying he wants to use it. My point is, when enough patients and enough doctors and enough nurses love the Care Wallet, all of these people will fall in line. We're going to follow the Apple model, create the demand, make the patient super happy, make the doctor super happy. All the rest of it becomes irrelevant. All the CISOs and the custom integrators and the gatekeepers for various EMRs, they suddenly will be like, well, guess what? My doc loves it, so I'm going to have to figure out how to use it. In the end, there is not a hospital or a pharmacy or a lab or a chiropractic clinic or a pediatric clinic that works when the clinician says, if you don't give it to me, I'm out of here. That's when everything changes. So everybody else forgets that their power is only limited to when the physician says enough. And I believe that EMRs have reached a point where physicians are about to say enough the moment you show them an alternative that works. So we are not going to compete with the entrenched interests. We are just simply going to make ourselves more valuable so that they cannot stand in our way, because the doc and the patient wants to use our platform. Therefore, it brings us back to Care Wallet. Make it sexy, make it cool, make it easy, make the cards beautiful. Grandma loves it. Grandma's doc loves it. The hospital will fall in line. All right. Let me read this one. Long question. Attending different conferences is a great way. Okay. So here's a funny thing. In 2022, because of the war, because I was in Ukraine a lot, especially from February to July was a tough period for everyone. There was not very few conferences we could actually go to. I did a lot of virtual, but physical conferences were not so many. But since about July, every conference I've gone to, and I've gone to about 5, maybe more, but around that, every single conference has generated tremendous client activity. We don't have a big sales force. We don't have a big marketing team. We simply have a massive pipeline from the fact that I speak at conferences, and doctors and hospital administrators and government execs who are there go, oh my God, I got to talk to you. And from there to a MOU or a workshop or a care journey, literally is weeks. So we have a fantastic pipeline based on the conference attendance. So we have realized that our fastest growth engine right now is conference presentation and participation. And we are going to be very, very focused on that next year. I will be on the road a lot more at conferences. Plus the COVID fears are receding, although I think it's too early. My personal opinion is COVID's going to stick its ugly head up again this winter. But regardless, people are more comfortable traveling. Conferences are coming back to life. And we intend to be both online and in-person conferences. And you will see a lot more of me on the road on that front, because it is the best use of our money when it comes to business development. Okay, great question. The Solve.Care's market cap, I think, is not really comparable to other tokens in the sense that we are a B2B2C platform. And our token utility to date has been B2B. The B2C component comes now with the authorizable care networks. No matter how big a care network we launched in the past, because the token transactions are happening between the network client and us, those network transactions aren't retail transactions. They don't show up in the retail market. They don't show up on the blockchain in a way that a retail platform would. So the market doesn't respond to our success because we are the B2B side working well. The B2C wasn't there. Now with Care Wallet and interoperable care cards and Solve as gas and Solve as fee and Solve as payment token and networks being authored to use Solve automatically, the B2C part comes in. And as B2C networks get authored and launched in 2023, and there's not one, there's many, then I think we will see a hockey stick growth in Solve utility as perceived and visualized by the market. Our utility is too much under the water. People don't see it, therefore it doesn't exist. It's like the tree falling in the forest. If nobody saw it, did it really fall? So we are crossing that chasm with the authorizable cards and authorizable network. And I think as all the authored networks or any number of authored networks start to go live and the Solve transactions become visible on the blockchain, all of this becomes a non-issue. Personally, I think Solve will, this is just my personal opinion, 100 million is not a comparable number to Solve.Care. Solve.Care will stand at a whole different league of its own because we are talking about addressing a $10 trillion a year market. So I'm not worried that it's not there as a market cap today and never was, never will be, because to me, we have done what really matters, is to build a healthcare platform that in the hands of a doctor can engage their patients, and the doctor and the patient can transact safely and reliably. And yes, Solve needs to be there. So clearly, the Solve as a gas fee and payment is foundational to driving this utility. But there's also a few more things we can do and will do, which is to think about other enhancements beyond the fee, gas, and payment model of Solve. What else can we add to Solve as a utility? And there are ideas that are being discussed in enhancing the Solve tokenomics. And actually, I will probably run a poll with you all to get your thoughts on other token economic changes or enhancements that make Solve more retail-oriented. So in a nutshell, Solve is currently used in a B2B setting. 2023, Solve becomes a B2C token, and I want to make sure that it is the de facto B2C token in healthcare. And that seems to be all the questions. I'm surprised. I hope we didn't miss any questions, guys. Let me check in with the team to see if there are other questions. Solve team, do we have any other questions that we have received from the community during the AMA? I don't see anything posted on Telegram chat. Okay. All right, guys. So let me wrap up this AMA by saying, again, it's been a tremendous year. 2022 is not a year I would ever wish to repeat in my life. For the number of friends I saw damaged and hurt, and they suffered terribly more than we did. So I would not want this year to be repeated again for any of you in terms of the global political climate that we now live in. But it was a great year regardless. The team pulled together miracles. Our pipeline is fantastic. Our platform has reached a really fantastic time where it can now lead to authoring networks in the form of cards and journeys at a breathtaking speed. The protocol is enhanced significantly. A lot of stuff is coming out on the protocol that you will love to hear. Maria has got a series of announcements for you over the next coming days. I know that if we were to simply announce one major accomplishment, we'll be making an announcement every single day, but I think she has a plan to give you guys bring you up to date on everything we have accomplished this year, and there's a lot. We enter the year strong in terms of customer pipeline and our ability to deliver customers. Where I want to focus on next year is launching as many B2C networks as possible. GTHE, Definitize, Care Marketplace, Second Opinion. These are just a few that we plan to launch early next year. We will continue to make authoring process simpler. There's a lot of work happening there. But most importantly, the focus is on revenue. The goal for Solve.Care in 2023 is maximize the value of our platform and have that reflect in token-driven revenue, which means there's revenue and there is Solve utility, and they are two sides of the same coin. So we want to show the market that our revenue reflects an equivalent market activity because there has to be more retail transactions around Solve.Care that B2C networks will drive and permit. So with that said, nothing is ever easy. 2022 wasn't easy. 2023 will bring its own challenges, but I'm excited with what we did in a tough year. And I believe 2023 is our year. We will explode in network utility, in token utility, in wallet downloads, in number of cards and journeys that are active on the platform, the interoperability side of it. These are milestones that we have either achieved or expect to achieve in the near future. I wish you all a great holiday season. I wish you to be well, be healthy, be safe, be grateful, enjoy everything and everyone around you. And I'll talk to you right after the holidays. Have a good one, and thank you, everyone.